Next speaker is a very senior pan-ophthalmologist, I should say. He is the medical director of Amardeep Eye Hospital, Kollam. Dr. J. Prasad Bhaskaran will be talking on iris sutured IOLs. Over to you, Dr. Sir.
Good morning. Thank you, Dr. Lakshmi, for this opportunity. So I'll be talking on iris sutured IOLs. It's a secondary option. My armamentarium is nanceroprolene always on a straight needle, which I try to manually curve to get a curved needle. The ones that are available here from Orolab are not very stiff, so it's not that good, but you can manage. You can use a regular Sinskey's hook, bend it a little so that you can retrieve the sutures. You need a pair of micro scissors, an anterior vitrectomy set, and the lens of choice is a 3-piece IOL from Johnson & Johnson. I have no financial interest. Why? Because the anterior edge is always curved. Always use lenses with a curved anterior edge. The posterior edge is, of course, sharp to prevent PCO. And I always use parabulbar block. And here I go, aphakic eye, 2 side ports, 1 main incision 2.8, 3-piece lens implanted into the sulcus, the so-called sulcus, leave the optic in front, go from the side with a 23 gauge micro forceps, catch hold of the optic, and then bend the haptic and try to bring it down. The pupil is so much constricted, but it does go and come back again, and then you just nudge it in so it goes behind, and you shoehorn the iris behind the optic. So the optic is in front, the haptics are behind. It will sit there. You can use pilocarpine so that it doesn't dilate and the lens drops down. Now you use the needle, straight needle curved. From the left side, you lift up the optic and go through the iris under the haptic and come out through the iris and come out through the cornea. You don't put a second incision. You bring out a loop using your Sinskey's hook. So loop is there. Catch the free end of the loop. That is the end that has come out through the cornea. Go 3 rounds clockwise. Catch and catch from both the sides. This is a modified Siepser knot. Do that 3, 2, 1, and then you repeat it for the other haptic. Same way. Please remember, when you go through that side port with the needle, don't go lamellar. Always go through that opening, the parasynthesis opening. You cut off the excess suture so that it is tight, and once you are sure it is tight, you gently nudge the IOL optic back behind the pupil. Ensure that there is no vitreous remaining in the anterior chamber. This is very important. You don't have any strands coming into the wounds because there is no PC here. And once that is done, you can go to the periphery and do a small iridectomy. That is an iridectomy. So 2 iridectomies. Please remember, this video is running at a very fast pace. I never operate this at this pace. It is always slow, and slow. And don't have 14 patients waiting when you are doing this surgery. Do it. Try to do it after lunch or first in the morning, and don't have so many patients on that particular day to operate. Another patient where you have some residual PC sitting there, shriveled with a small capsular opening you can see in the center, almost more than 180-degree sonular loss. Once again, here you are much more comfortable because you are sure that the lens will not drop straight into the vitreous, even though there is a big gap. So use OVD, dispersive OVD, dial the lens into the sulcus and lift it up. Lift with 2 instruments, bring it up so that the optic is caught by, shoehorned by the iris, and then you go through the side port. Remember, the side port has to be, for introducing the needle, it has to be a tangential parasynthesis. It's not your regular parasynthesis. It should be in the direction in which you are going to pass the needle. Lift up the optic. You can see the mark of the haptic through the iris. So you can go underneath that. Try to take a smaller bite and then go through an intact cornea near the limbus. Bring out a loop. Catch the free end. Once again, I am showing this 3 rounds clockwise, catch and pull from both sides so that you don't drag the iris this side and that side. Inject more OVD at that point. Go back again, use that modified Sinskey, catch, rotate 3 rounds, catch the other tip and then catch from both sides. So 3, 2, 2 or 3, 2, 1 you can put, and the third one. Remember that when you are doing this, please, you should ensure that the iris is not pulled this side, that side. Then you will tear the iris, you can have iridodialysis. This has to be done in a very, very controlled fashion. And once that is done, you can cut off the excess proline from both sides. Ensure that it is reasonably well centered. Try to get the iris as far towards the limbus as possible and not toward the center to avoid some amount of ovaling or the pupil getting distorted. Once that is done, you can go behind, cut off the capsule as well as a minimal anterior vitrectomy in the center, and then you can push the lens back into the behind the pupil. Once again, let me tell you that this is a procedure you should do slowly, slowly and slowly. This is a descended eye, a PMMA lens. Now before you put it, use the lens, ensure that the haptics are intact. Sometimes the original surgeon would have broken the haptic. So ensure, inspect, and in the same position, lift up the iris and see. Once again, brought it up. This is a PMMA lens. Any PMMA lens you can use if the anterior edge is curved. It should be, most of these PMMA lenses have 10-degree angulation, so there is no issue. The same procedure can be done. This is a pseudo-exfoliation patient where you anchor on both sides. The same one is, the same lens is used, and go behind the lens and cut off the residual capsule and whatever cortex was there. And once that is done, you will invariably leave behind a small, slightly oval pupil. Exactly round eye get only in 60%, 40% definitely have an oval pupil. So if it's a young girl, probably you should not do it for aesthetic reasons. You may go for a scleral fixation. Once again, slow, slow and slow. And this is finally, the pupil is not available to hold on to the optic here because the pupil has been distorted in the previous surgery, but the iris looked reasonably all right. So I have put a bridge of tensuro proline suture, which is goes from pars plana to pars plana, come out and then come back and sutured onto the surface of the conjunctiva. Then you keep that IOL over that and dial it into position, anchor the haptics, and then take off the suture. So this will prevent that lens from dropping down into the vitreous immediately while you are anchoring it to the iris. Complications, possible complications, oval pupil is the most common. You can have glaucoma, pigment dispersion, cystoid macular edema 10%, iritis, and of course you can get like iris claw or scleral fixated or scleral sutured and IOL drop. I had an absolutely good record. I never had an IOL drop till last week when I dropped one lens. Thank you. Thank you so much.